Hello, my name is Jimmy Limdi and I'm a consultant gastroenterologist and head of the inflammatory bowel disease section at the Pennine Acute Hospitals in Manchester in the United Kingdom. My co-authors, Drs. Pico and Dr. Ferre from the Mayo Clinic, and I would like to thank the editors for the opportunity to present a video summary of our review article entitled A Review of Endoscopic Scoring Systems and Their Importance in the Treat to Target Paradigm in Inflammatory Bowel Disease. In this review, we provide a comprehensive narrative and pictorial review of endoscopic and histological scoring systems and their potential role in IBD treatment to target paradigms. Inflammatory bowel diseases comprising Crohn's disease and ulcerative colitis are chronic, relapsing and remitting progressive diseases which are immune-mediated, affecting the gastrointestinal tract. Recognition of the potential disconnect between clinical symptoms and objective measures of disease activity and evidence that uncontrolled inflammation can lead to progressive intestinal injury with irreversible bowel damage and adverse consequences has redefined our perceptions and paradigms as to what constitutes meaningful disease control. The principle behind treatment beyond symptoms is to treat disease activity early and effectively before intestinal damage occurs and irreversible disability occurs, and this has led to the concept of treating to target. The treat to target concept was developed by the STRIDE committee comprising experts from the International Organization for the Study of Inflammatory Bowel Diseases, or the IOIBD. It implies the identification of a predefined goal which is known to be associated with better patient outcomes in consultation with the patient, and then selecting and then optimizing and monitoring treatment until that goal is achieved. Objectively, this means resolution of abdominal pain, normalization of bowel habits, and endoscopic remission, or cross-sectional imaging as in the case of Crohn's disease affecting the small bowel where endoscopy may not be feasible. Mucosal healing has been shown to correlate with a sustained clinical response and reduction in important surrogates such as corticosteroid use, hospitalization, surgery, and the development of colorectal cancer complicating IBD. Endoscopy remains the gold standard for mucosal assessment, the judicious and periodic use of which enables optimization of medical therapy and facilitating treatment to target. Mucosal healing, or more accurately endoscopic remission, is currently defined as the absence of ulceration in Crohn's disease and the absence of mucosal friability and ulceration in patients with ulcerative colitis at sigmoidoscopy or colonoscopy. Several endoscopic systems have been developed in Crohn's disease and ulcerative colitis with the aim of providing objectivity and enabling the definition of mucosal healing as an endpoint in clinical trials. Real-world endoscopic reporting, however, is arguably limited by inconsistency with the use of standard scoring systems. It is difficult to describe what has not been adequately defined, which creates imprecision and variance in reporting through a significant interpretative element. Endoscopic scoring systems provide objectivity, uniformity, and standardization of mucosal appearances, augmenting clinical decision-making and ultimately affecting appropriate treatment targets and desirable patient outcomes. The most commonly used endoscopic scoring system in the case of ulcerative colitis is the Mayo endoscopic score. Mucosal healing here has been defined as a subscore of 0 or 1, although this has not been formally validated. Addressing the need for a prospectively validated tool to assess mucosal healing and applicable to clinical practice, two further clinical scoring systems were developed: the Ulcerative Colitis Clinical Endoscopic Index of Severity and the Ulcerative Colitis Colonoscopic Index of Severity. The UCEIS is simple to use in clinical practice and has now shown strong correlation with patient-reported outcomes, making it suitable in clinical trials. As with the Mayo endoscopic score, a UCEIS score of 0 is associated with a lower risk of relapse. Moving on to Crohn's disease, there are three endoscopic scoring systems, namely the Crohn's disease endoscopic index of severity, the simple endoscopic scoring system in Crohn's disease, and the Rutgers endoscopic score for grading in post-operative recurrence of Crohn's disease. The IOIBD defines endoscopic remission as a score of 0 to 2 and endoscopic response as a greater than 50% reduction in the SESCD score. The SESCD score is probably more suited or better suited for clinical practice. The Rutgers clinical score is used to grade lesions and in the neoterminal ileum for the risk of postoperative recurrence. Earlier, colonoscopy is recommended 6 to 12 months after a surgical resection to determine and prognosticate the risk of clinical recurrence and then optimize treatment as necessary. The IOIBD considers an Rutgers score of I0 or I1 as the definition of remission after surgery. Technological advances have now enabled assessment of the small bowel with capsule endoscopy, and there are several scoring systems applicable in small bowel capsule endoscopy scoring, which have also been discussed in our review. A growing body of evidence suggests that histological remission may be the new goal in the treat-to-target paradigm, at least in the case of ulcerative colitis, although this was not recommended by STRIDE due to lack of relevant supporting evidence at the time STRIDE was written. Ongoing colonic inflammation increases the risk of colonic neoplasia, encompassing dysplasia and colorectal cancer. Taken together, the risks of persistent inflammation and the benefits of mucosal healing provide an added impetus towards achieving deep remission. There are various scoring systems available for ulcerative colitis, of which the Nancy scoring system and the Robarts histopathology index have undergone the most validation, demonstrating a high concordance with endoscopic disease activity and fecal calprotectin. Histological scoring systems for Crohn's disease, meanwhile, are limited by the discontinuous nature of the inflammation and transmural nature of the disease. Although the pivotal role played by mucosal healing has been recognized as driving favorable outcomes, whether this bar should be unequivocally raised to achieve histological healing remains to be established. In conclusion, modern and evolving definitions of inflammatory bowel disease acknowledge the progressive and potentially disabling nature of IBD. Endoscopic mucosal healing corroborates with sustained clinical response and reduces morbidity from corticosteroid use, hospitalization, surgery, and colorectal cancer complicating IBD. Endoscopic scoring systems provide objectivity, uniformity, and standardization of reporting of mucosal appearances. Despite being somewhat limited by their complexity, subjective interpretative elements, and lack of validation for some, their strength lies in their ability to augment clinical decision making and ultimately having an impact on the appropriate treatment targets and desirable patient outcomes. The real-world impact of these rapid strides and the altruistic pursuit of meaningful targets, however, hinges on the universal adoption of these endoscopic systems and clinical scoring systems in practice. It is only then that we will realize the virtues of such personalized medicine exemplified by our treat-to-target approach. Thank you for listening.